Once again, hyper slows the heartbeat, hypo elevates it. But the biggest thing that the calcium is going to play a part on that's going to create issues is the actual strength of the contraction. So it will actually make the contraction stronger or weaker. And that's going to create problems with moving the blood into those great vessels, getting them to the lungs and to the systemic circuit. So when they begin to see any type of issues like these, which usually come about as we age, come about with different conditions that show up as we age, and certain medications that people are on can affect their levels. Like if they have to be put on certain medications, they might have to come in like every so often, have blood work to check these levels. They might have to watch their diet because the levels may be affected. People who may have kidney disease and the medications they're on are going to cause them to have watch their diet and maybe take medication to control these levels. So I pretty much can guarantee that as you go out into the clinicals, as you get out into your chosen programs, you're going to encounter those. You're going to encounter these issues of these ions being out of balance. That stroke volume that we mentioned, because remember, cardiac output is my heart beats, that heart rate, times the volume, that stroke volume. Well, under the normal conditions, that roughly 70 milliliters, that changes. There are some variables that are going to affect my volumes. It can be what we call preload, afterload, or contractility. Now, preload, afterload, this makes me, I don't know about you guys, but that makes me think about the amount that's present, okay? The amount before we get to that heart, the amount after we get there, okay? One of the things about the heart and this structure it's muscle tissue. What fibers do we find? We got collagen, we got reticular. We're definitely going to find collagen fibers. What was the third one? Elastic. Now, let's think about this for a second. It's muscle. Just like we would, and which muscle was it very closely related to? Skeletal or smooth? Skeletal. It had a very similar appearance, very similar structure of our actin, myosin, that sort of thing, okay? Now think about, okay, don't use it, you lose it, okay? So for example, maybe you're like really good activity-wise and maybe got some good muscular tone or really big muscle, but anyway, you know, so you've got maybe the really good muscles, but then one day you reach an age and you go, you know what, I'm tired. That's it. I'm done. Stick fork in. Now, what begins to happen to that muscle that was toned and had a lot of the protein, the actin and the myosin, everything in it for function and all that sort of stuff. What begins to happen to that muscle? They kind of atrophy, decrease in size, not quite as quick to function as they were, a little more buildup of the fat around it and that sort of thing, okay? The heart is a muscle also. One of the things about it, people who are more active have a more conditioned heart. People who are more sedentary do not. And just like skeletal muscle, okay, more active, better conditioned, the better its function. All right? Sedentary, not. Okay? And more fat will actually build up around the organ itself, which definitely puts a strain on it. So, the tension or the stretch of this muscle itself is important. Lots of things can actually affect the stretch of these cells, okay? But what we want is we want to make sure that it stays healthy. So, the tension or the stretch of these ventricles before contraction is my preload. The better trained they are, the better conditioned they are, the more they're ready to contract. Does that make sense? Okay, so in times, like I said, because the volume changes, okay, think of that conditioned individual, that conditioned athlete who's going to have more volume returning to their heart at those times of doing the exercise, and this volume increases. The good thing about the structure of these cells, they will allow for stretch to occur. It will allow a stretch for a certain amount for the blood that's moving so fast at that time of exercise, all right? But it meets that demand. And so if we get an increased venous return and it stretches, we get that ability for it to stretch, but at the same time be able to still give us a good contraction, keeping the blood flowing, all right? It'll expel the blood a little more forcefully, but that's okay because this is what the body has been conditioned to do. In my current condition I'm in, if I were to try to leave here and go make a 5-mile run, I'll guarantee you within 10 feet I'm falling out because I'm not conditioned. My heart's not conditioned. Those little cells are going to be like, what? Oh, no. And they're going to rebel, okay? So I would have to work up to that. And every time I do something to work up to it, I'm training that heart muscle at the same time. So those people who are well-conditioned athletes, they didn't just come that way in one day's time, all right? They did that over years and decades, getting to that point. We have, with the heart, a law. It's called the Frank-Starling Law. And that law says the ventricles will eject as much blood as they receive. Does that change, or can that be affected? Can there be issues? Yes. But there are other physiological conditions present making that happen. For example, blood pressure. People who are under chronic high blood pressure that is very difficult for them to control, their hearts enlarge and their contraction strength weakens, and this is why there's so much concern about people with high blood pressure, among a lot of other things. So basically what would happen, based on the structure of these with the collagen and a little bit of elastic, okay, those protein filaments, they would stretch out and not be able to recoil. So that becomes a problem. If that were to take place, I don't have the tension I need, my preload changes, and therefore my stroke volume would change. Does it make sense? Which would affect my entire cardiac output. Because cardiac output is heart rate times the stroke volume. The contractility, contraction. Basically, how hard is the myocardium contracting? We're going to say that factors are either positive or negative inotropic agents. There are way too many of them to study, but the ones that we do know play a major part are calcium and potassium. They are going to affect the contractility. Calcium is positive and can strengthen the contraction. The potassium is negative and decreases it. Under normal conditions, if the heart's contracting normally, that blood flow ejecting out is normal. However, if there's something that affects it positively or negatively, if I increase the strength, if I decrease the strength, I have now decreased the movement of the blood, which is going to affect my stroke volume, which is going to affect my cardiac output. Yes, no, maybe. Afterload. The sum of all the forces, my blood pressure, my blood volume, the movement of the blood from atria to ventricle, the sum of all the pressure, all the forces that are acting on the blood ejecting from the ventricles, okay? Biggest one, blood pressure, high blood pressure, low blood pressure, both, okay, can affect what my heart has to overcome. If it cannot eject all of the blood in the ventricles, I have now affected my stroke volume, which affects my cardiac output. These are all values that cardiologists and at times of different issues of people coming in with heart problems are going to have, they're going to be looking at. We do know a big factor on afterload are lung diseases. Why? If we look at the circuit from the right side of the heart, it goes to the lungs. If there is anything in the lungs that's going to be restricting them, that is going to affect the blood moving into those tissues. One that's very common, because as we age, as different disorders show up, depending on physical condition, depending upon lifestyle and so forth,